So how does iron is absorbed? Now in diet, if you see in diet, iron is in the form of Fe3. And you know all ions are absorbed in divalent or monovalent form. So it will have to be converted into divalent form. So our intestine epithelium has reductase. Okay. Our intestinal epithelium has reductase. This reductase, ferric reductase. So it will reduce this iron into ferrous form. And this ferrous form will be absorbed by DMT, divalent metallic transporter. Okay. And this, in order to pass through this membrane, always it has to be in this ferrous form. This ferric form will not be absorbed. And once it is absorbed, if it is deposited, it will be deposited in ferritin, in enterocyte. It will be deposited in the form of ferric again. But if it has to go into the circulation, it will again, ferroportin protein will actually transport out of the enterocyte to this. And after transportation of ferroportin, there is other protein. This is hepcidin. Actually, this other oxidizing protein, it will immediately oxidize into this. After transportation, it will oxidize into this ferric. Transportation form is also, this is transported also in the form of ferric. Only stored also in the form of ferric. Only absorption is ferrous form. And then transportation, this absorption, whenever this iron has to cross this membrane, you will see it has to be in the form of ferrous. So this is the uniqueness about iron absorption. It is absorbed always in the ferrous form, and then again it will be excreted also in the ferrous form from the enterocyte into blood, and then transported in ferric form in transferrin protein. Name is, the iron transporting protein is called transferrin. Transferrin protein is this type of protein, you can say 8-shaped protein, you can say dimer protein. There is one iron will bind with one protein, other iron, ferric iron will bind with other protein. So transferrin binds 2 iron molecule. One transferrin molecule will bind 2 iron molecule. You can see here this hepcidin, actually intracellular this is actually hepcidin. This is not hepcidin, this is hepcidin. Hepcidin actually oxidized. This oxidized Fe2 plus 2,3. And this is hepcidin is something that is released from liver. This regulates the concentration of this iron in your body. This regulates the concentration of iron in body. What does this hepcidin, if there is very high hepcidin, so actually, okay, I will tell you. So if hepcidin is very high, if iron in body becomes very high, this will actually, iron in body becomes very high. This will cause increased hepcidin release from liver. And this hepcidin, what does it cause? It will actually inhibit this. And because of that, what will happen? If it inhibits, this absorption will also be inhibited. So hepcidin actually inhibit intestinal iron absorption. Okay, intestinal iron absorption. And this high iron will increase the release of hepcidin. So this is like feedback mechanism of iron absorption. So high hepcidin will decrease iron absorption. How? By inhibiting this ferroportin. This is feedback mechanism. High iron inhibit this. And liver releases iron regulatory factor called hepcidin. When hepatic iron ferric store is full or free iron is very high, so it will cause release of this hepcidin. And then hepcidin will cause reduced absorption of. This is feedback mechanism for iron absorption. So you can see this 43-year-old man present to, and I will tell you one more thing. This iron absorption is a one-way traffic. One-way traffic. Iron absorption is one-way traffic. There is only absorption. There is only absorption. No elimination, no excretion. This is a very important concept. Because of that, what will happen? If iron is absorbed in very high quantity in our body, iron will actually be deposited in very vital organs. This is called hemochromatosis. So we'll see. 43-year-old man present to a primary care physician for first time, complaining of worsening joint pain, decreased libido. Okay, over the past 2 years, basic laboratory workup reveals hyperglycemia. Note this point. On physical examination, patient is noted to have bright tan despite his work as a cardiologist. Ultrasound reveals liver cirrhosis. Note this very important point. Now, bright tan you can see by radiologist in visceral organs, you can see. And then increased serum iron. And then transferrin saturation is also increased and ferritin is decreased. Decreased TIBC. TIBC means, remember, TIBC. Okay, TIBC is correlates with the saturation. Okay, means this is correlates with the transferrin. No more is the TIBC, more will be transferrin, less is the TIBC. So I will tell you a little bit about this. So remember, this is actually iron overload, and iron overload in visceral organ, in pancreas. Iron overload in pancreas will cause diabetes and then hyperglycemia. Iron overload in liver will cause liver cirrhosis. Okay, this is the reason this radiologist see bright tan in when he does sonography examination, radiological examination, when he radiological investigation. Actually, in X-ray also there will be bright X-ray. So this is, you can see, hematochromatosis, hemochromatosis. Abnormal this gene cannot regulate iron absorption. Okay, so this gene, abnormal in this gene, cannot regulate iron absorption, and this gene actually is hepcidin system will become less effective, resulting loss of negative feedback and toxic. So low hepcidin is there. Hepcidin cannot be produced by this gene, and if hepcidin is not there, continuous iron absorption. And because iron absorption is one-way traffic, so it will be deposited in liver, it will be deposited in other places, in pancreas, in other visceral organs. It will cause diabetes and other problems. So this is called bronze diabetes. So hemochromatosis is called bronze diabetes.